Welcome to the CTSNet original webinar, Unifying Revascularization Guidelines Across Continents to Specialties. Thank you for joining us. Please note this webinar is being recorded and will be available next week on ctsnet.org and CTSNet's YouTube channel. At this time, I'm pleased to introduce the moderator for this webinar, Dr. Faisal Bakin. Dr. Bakin is cardiac surgeon in the Department of Thoracic and Cardiovascular Surgery in the Seidel and Arnold Miller Family Heart, Vascular, and Thoracic Institute. He is also a professor of surgery at the Cleveland Clinic Lerner College of Medicine, located in Cleveland, Ohio, in the United States. Thank you for heading this important discussion, Dr. Bakin. I'll turn the panel over to you.
Thank you, John, and thank you for joining us. I'd like to express my appreciation for CTSNet for hosting this, and I have an incredible panel that would discuss with me today how we're going to unify the vascularization guidelines across the continents and specialties. This is going to be very lively. We've had over 400 registrants, and we're really excited to do this together. Without further ado, I'm going to present our esteemed panel member, starting with Dr. Don Huey, who is the professor and vice chair for quality and research at University of Texas Long School of Medicine, San Antonio in the United States. And Dr. Michael Farkouh, who is the professor of cardiology and a research scientist at the Smith Heart Institute at Cedars-Sinai, Los Angeles, United States. Our prayers go out to you and all the people that may be affected by the fires in LA. We hope that they'll control them very quickly with minimal damage. And that applies to anybody from California joining us today. Next is Dr. Doenst, who is a professor and head of the Department of Cardiac Surgery at the University Hospital of Jena in Jena, Germany. Thank you for joining us, Torsten. And then last but not least, Elimir Omerovic. Dr. Omerovic is an interventional cardiologist. He's a professor and principal investigator at the Department of Molecular and Clinical Medicine, University of Gothenburg in Gothenburg, Sweden. Thank you very much for joining us, and we're very excited to start this. I would like to quickly remind the audience that they can type in questions at any time for the panelists and use the Zoom Q&A to do that. Without further ado, we would move on now and have Dr. Huey present to us on the key differences between the European and the ACC/AHA revascularization guidelines for CABG. Don, the floor is yours.
Thank you, Dr. Bakin. Thank you for that introduction, and thank you to CTSNet. It is a real honor and a pleasure to be part of the discussion today on unifying revascularization guidelines. And good morning, good afternoon, and good evening to our audience. These are my disclosures. While I have some editorial board duties, all opinions expressed here are my own, and I have no financial disclosures. Here's a brief outline on the key differences between the European and American guidelines that I will be discussing. And the first key difference is the representation of the surgical viewpoint in the final writing committees and the endorsement of the guidelines by surgical societies. So from page 1 of each document, the difference is apparent. The ESC guidelines had 2 esteemed cardiothoracic surgeons on the writing committee, and the document is endorsed by EACS. In contrast, the final writing committee of the 2023 AHA-ACC guidelines had no surgeons listed, and this was due to the withdrawal of the STS and AATS representatives over significant concerns stemming from controversies generated from the 2021 guidelines, concerns that were propagated and not fully addressed in these 2023 guidelines. And proposals by these representatives to address the concerns were disregarded. And thus, rather than endorsement, the 2023 AHA-ACC guidelines were in fact rebutted by multiple surgical societies, similar to what had occurred with the 2021 guidelines. Now, the 2024 ESC guidelines on the mode of revascularization for chronic coronary disease are shown here. Organized by anatomic and clinical basis, they are clear and comprehensive and covering the gamut of different patient scenarios, accounting for anatomic location of the lesion, the complexity of the coronary disease, and patient comorbidities. Shown here, the 2023 AHA-ACC guidelines, specifically addressing the mode of revascularization, are organized differently. They are fewer in number, and as we will see, they take a different approach to the interpretation of the evidence, as my colleagues will further discuss. And shown here in a more tabular format for comparison, one can see that the European guidelines give an overall Class 1 recommendation for CABG in the treatment of left main disease with or without concomitant multivessel disease, over medical management for survival benefit, and over PCI for superiority for repeat revascularization and spontaneous MI. PCI for left main disease with less than high complexity is recommended, provided that equivalent completeness of revascularization can be achieved, with a Class 1 recommendation for low complexity disease and Class 2A for intermediate complexity disease. We expand the table to accommodate some very specific granular details noted in the American guidelines. For left main stenosis, the AHA-ACC guidelines also give CABG a Class 1 recommendation over medical management for survival benefit, and over PCI for left main stenosis with high complexity disease, also citing survival benefit. In contrast to the European guidelines, PCI is given a blanket 2A recommendation, again, provided that equivalent revascularization can be completed. But for patients with diabetes and low or intermediate complexity, this is downgraded to 2B as an alternative to CABG. For the treatment of multivessel disease, there is much more discordance across the two guidelines. The ESC guidelines give a consistent Class 1 recommendation for CABG for all patients, with the only recommendation for PCI being patients without diabetes who have low to intermediate complexity and preserved ejection fraction. The AHA-ACC 2023 guidelines give CABG a Class 1 guideline for two scenarios only: multivessel disease in the presence of diabetes with LAD disease, or with severe systolic dysfunction. CABG for multivessel disease with high complexity is given broadly a 2A recommendation. Of particular note is the recommendation for multivessel disease in the absence of diabetes, absence of high complexity, and absence of systolic dysfunction. Here, in stark contrast to the European guidelines, both CABG and PCI are given a 2A recommendation. And in fact, to be precise, the 2023 American guidelines did not set forth separate recommendations for PCI or CABG for this category. Rather, there was a single recommendation for revascularization, whether by PCI or CABG, in addition to medical therapy, rather than medical therapy alone, to lower the risk of cardiovascular outcomes. And as we'll have the privilege of hearing Dr. Doenst discuss later, the mechanisms by which PCI and CABG differ is important. So my personal opinion is that separate recommendations to address different benefits should be issued for each of these modalities. In addition to the level of recommendation, the specific benefits cited differ in the guidelines, with the European guidelines citing survival benefit of CABG compared to medical therapy for multivessel disease, while PCI for low to intermediate complexity was qualified as providing non-inferior survival. And here are some of the papers supporting the survival benefit of CABG. And while we have discussed the 2023 AHA-ACC guidelines, this difference in survival benefit was acknowledged in the 2021 guidelines, which stated that in patients with chronic coronary disease and preserved EF, CABG offered improved survival compared to medical management, while the survival benefit of PCI was uncertain. In spite of these differences in survival, CABG had been downgraded to a 2B recommendation, and these guidances in the discussion of survival benefit completely disappeared from the 2023 guidelines. So stepping back, we can perhaps see a picture that these key differences are likely interrelated. Thank you for your attention, and I look forward to hearing my colleagues delve further into the implications of these differences and how we can reconcile them.
Thank you, Don. That was really fantastic and clear and to the point. So we have different recommendations across the continent, yet pretty much the same evidence. So, Mike, how could you explain that? Maybe you could explain to me in the audience, because I'm still puzzled by that.
Thank you, Faisal, for having me. I'm a cardiologist. I consider myself the consumer. And although cardiologists perform interventional cardiology, the likelihood is that we're really posed with the dilemma, when do we revascularize and how do we revascularize? The idea is that we really are faced with interpretation of guidelines, which are, there are some discrepancies. I want to give you the evidence of why and where the discrepancies may arise from, and then try to explain. So let's set the stage. So what is optimal medical therapy is really key to this whole argument. If we don't have optimal medical therapy, it doesn't really matter which way we revascularize. And we define that by systolic blood pressure less than 130/80, and LDL cholesterol less than 70, which is largely now being abandoned in favor of even less than 50 milligrams per deciliter, and glycemic control in the setting of dysglycemia or diabetes. But we must understand that it's about mortality is important to present to a patient. And we have the issues of 3-vessel disease without diabetes. We have the issue of diabetes, and we have the issue of LV dysfunction. Now, this all gets down to this quote. I want everyone to remember this from Mark Ruel, who said to me in 2015, the absence of a difference does not mean the difference is absent. This has to do with the subgroup analyses. So unless a trial is powered for a particular question, we're always going to have misinterpretation or different interpretation of the evidence. So subgroup analysis, even from large, carefully conducted, randomized trial, is often underpowered. And so the idea that we have the answer for every one of these subpopulations is not true. And that's where the discrepancies arise. Now, also, ischemia was important. I have a number of issues of the ischemia trial, which was not a trial of revascularization or not, or medical therapy versus revascularization, but was a trial of how we evaluate patients to present for future medical or revascularization strategies. So it's not true that in the byline of the New York Times, ischemia, PCI, and surgery strike out. It's not true. This trial did not address that question. And that is also a source of the discrepancy in the trials between the American and European data. Let me just go down to the fact, go to the next slide here. So the idea that we have strategies that favor revascularization on one hand and types of revascularization on the other come from our clinical practice. In patients who are frail, who have low life expectancy, that favors bypass. Also low syntax score, we talked about, Dr. McKean referred to this. This also helps to guide us. The simple, less complex patient may be more amenable to favor PCI. I'm talking about patients that don't get into trials, where we don't have equipoise. And of course, for surgery, we have the advantage of mortality benefit, not only in diabetes, not only in reduced LV function, but also in patients without diabetes. If you pull the data from the BEST and the Syntax trial, there is a mortality benefit for patients without diabetes who have multi-vessel disease and preserved LV function. So we must not argue from the perspective we don't have the evidence. It's how we interpret the evidence. The other issue comes from this slide, which I think is pivotal. And this is a slide from 20 years ago, which summarizes the entire field, in my opinion, where Don Cutlip looked at patients in the bare metal stent era, those that had bare metal stent placed versus not, and looking at the target lesion. Did we treat the target lesion? And when you look at the comparison of target lesion and non-target lesion, CV events accumulate early in the target lesion. That's why we spot well the lesion with PCI. We treat the focal lesion. But in fact, as you follow patients, most of the events after the first year or so accrue in the non-target lesion. And this is where systemic therapy is important. And this is where we have to obsess about it as clinical cardiologists. I just want to show one slide from Freedom that summarizes MI, spontaneous MI. Look at bypass. It's a flat curve. After the the peri-procedural period, the incidence of MI is flat, whereas the incidence of MI with PCI is a stuttering course because you're not treating those non-target lesions. This is something that must be emphasized. And finally, we talk about the heart team approach. And I think this is where the consensus from the European guideline really brings us home to the fact that we look at the pre-procedural period, the peri-procedural period, and the post-procedural period to customize our recommendations for individual patients. So why do we have discrepancies? We have discrepancies because it's in the not in the evidence, but how we interpret it. So syntax and freedom really set the stage for multi-vessel disease, but we've had other trials now confirm, and observational data confirm, that in fact there are differences in outcome for select patients who are on clinical trials. And the observational data confirms that we have generalizability to populations that don't get into clinical trials. We need to be very, very careful in how we interpret the guidelines. I believe that the new European approach is the one that brings clinical cardiologists, surgeons, interventionalists, primary care docs to the table with this heart team approach. And so I'm excited to talk about where we go next. But the idea that we have differences in interpretation is part of medicine. The guidelines are just that. They are guidelines. So Faisal, I'm going to stop there and look forward to the future discussions in this session.
Mike, thanks so much. As always, very sensible, very thoughtful. We need many more cardiologists and surgeons actually who think like you, because what you said really sums it up nicely and explains the nuances, how different people could look at the same data and maybe come up with slightly different recommendations based on the specific patient scenario. Now, you showed some really interesting slides about how the future events are occurring in non-stented vessels. Yeah. So I think that's a great segue for Torsten's talk, who's going to talk about the fundamental differences between stents and CABG as it relates to both treatment and future protection. So Torsten, the floor is yours. And I would encourage our attendees to keep submitting questions. We're getting a nice flow of questions. We're going to have plenty of time to discuss at the end.
So yeah, thank you, Faisal, and also thank you, CTSNet, for this for having me on this webinar and being able to participate here. This is a great discussion, great presentations, and I think that if you look at the treatment of coronary disease and you look at the way guidelines are generated, then there's always two ways of looking at it, and guidelines can only look at it from a data perspective, and they try to weigh the available evidence. We have actually generated an editorial to the last European guidelines where we try to connect this to a mechanistic thinking. And I think that's something that I would like to present here. And because I suggest that CABG and PCI are not, it should not be combined in the term revascularization because they deal with different mechanisms, right? So I have no conflicts of interest. So let's look at the revascularization paradigm. And in order to understand, for you to understand what I mean by this, let's review some of the pathomechanistic principles of what we do every day. So we say we revascularize the heart by either PCI or CABG, and that means we treat ischemia, we treat the symptoms. That means angina pectoris. We improve contractile function if it is impaired. We expect it to prevent myocardial infarction, and we expect revascularization to improve survival. And I think that everyone agrees with that. So what is the pathophysiology? This is a video from a friend of mine, and he shows this so that if there's blood flow and there's plaque development, and this plaque develops and it grows and it becomes vulnerable or not, and then it causes symptoms, and at one point in time it occludes, and then you get your myocardial infarction. Okay, so that is a common belief. But in the real world, the true mechanism, the main mechanism have to go back here. The main mechanism for myocardial infarctions is this. You have a plaque that's not flow relevant. and then that ruptures, and then a thrombus is forming, and that causes the occlusion. So, and bottom line is that here, the majority of infarctions here are happening at lesions that are not severe, that are not flow limiting. And PCI is only addressing the flow limiting stenosis. So that is one of the concepts. And that's why if you look at coronary artery disease from these pathomechanistic perspectives, you find three different types of clinical presentations. You have inducible ischemia, where you have a lesion that causes ischemia at exertion. You have to sort of stress it. And that's why we have to do stress tests to detect it. Then you have ischemia, that's the acute ischemia. And of course, the mechanism that you need is reperfusion, ischemia, reperfusion, that's acute ischemia. And the other thing is inducible ischemia, and the mechanism there is you restore coronary flow capability. You do not increase, there's no ischemia at rest. And then there's a third presentation that has nothing to do with the ischemia ongoing or chronic or inducible, that's the risk of infarction. And the mechanism there should be infarct prevention. So let's look at the trials that are out there. Ischemia has been addressed. Ischemia has done a lot of things, but it did detect inducible ischemia, and it measured the treatment of it. What did it find? Improvement in symptoms, no improvement in survival. Okay, so inducible ischemia treatment relieves symptoms. So what about maybe there's something like chronic ischemia, and maybe there's a reperfusion mechanism involved? And that is, of course, you need to have impaired ejection fraction, and the STITCH trial did that. And so the STITCH trial actually found a survival advantage, 1.5 years longer life in 10 years with CABG compared to medical therapy. But there's a problem, because how do you explain that patients without myocardial viability benefit from CABG? That doesn't make sense. Well, we have REVIVE, because REVIVE did the same thing as STITCH, inducible ischemia, low ejection fraction, revascularization, right? We treated it with stent. What was the outcome? No difference whatsoever, not even in heart failure hospitalization. So no difference in survival. So again, the reperfusion mechanism is out in the chronic setting, whether there is chronic ischemia or not. What we do does not prolong life. But then, of course, there is the potential of infarct prevention, or the risk of infarction, to reduce that. And that is no difference in REVIVE, and there is in STITCH, they didn't assess it, but there are all the other PCI and CABG trials, and maybe we can find some answers there. First of all these trials, here they had meta-analysis from the Lancet in 2018, showed that CABG has a survival advantage over PCI in these patients, mainly triple vessel and main and left main, right? So there is a survival advantage. And here, if you look at the infarction rate, and we've subtracted the infarction rates from CABG from stent, and this basically shows that the less myocardial infarctions occur in the CABG group, the better survival in the CABG group. So every time you see better survival, you see less myocardial infarctions. And that led us to develop this concept of collateralization, where you place a collateral here, place a graft for treatment of a severe stenosis. You also deal with all the other disease that's on the way. So if a vessel occludes, or if a lesion occludes, and that's what applies to Dr. Farkouh's message, that what he just showed, that other lesions cause problems, that is dealt with when you place a graft for this lesion. If you treat this lesion with a stent, you cannot do anything about what happens beyond that. And that is the problem, and there's the mechanistic difference. So we actually did a meta-analysis and looked at all the studies that compared CABG and PCI, and we found that CABG here is better than PCI. But if you have a difference in spontaneous myocardial infarctions between the groups, that difference is larger. In those studies that didn't find a difference in myocardial infarction, there's no difference in survival. So that goes to show that if you have inducible ischemia, you have a symptomatic relief. You can expect that. But you need to prevent myocardial infarctions, future myocardial infarctions, in order to improve survival in the chronic coronary artery disease setting. And not all infarctions are lethal. You can have, like in the NOBLE trial, No difference in PCI and CABG here in mortality, but a significant difference in CABG because not all infarctions are lethal. And if you look at the left main, for instance, then you see the same. No difference in mortality, but there is a difference in myocardial infarction, again, in favor of CABG. Always the same thing. And I could go on forever. So the higher the infarction risk, and the sicker the patient, the higher the infarction risk, the better treatment potential. And that's why you need to weigh surgical risk and PCI risk at the same time against this. And that's why, Michael, when you said that you need a conservative cardiologist in the heart team, I couldn't agree more. So, but then you have this medical treatment here, this left main registry, and they show that if you treat medically left main patients, you have this mortality and CABG and both PCI reduce it. So how do you explain a potential survival advantage of PCI? And there's a network meta-analysis from Windecker 10 years ago, and that was very, there was a big problem with it because the methodology was questioned. But they gave rate ratios here, risk ratios, so to speak, for all-cause mortality. But they also gave them for myocardial infarction. And if you compare, you already know this one here, CABG versus PCI. But if you correlate the risk of infarction to the risk of mortality in those studies that compared PCI and medical therapy, you find the same, a correlation again. So even in PCI, if there is an advantage, a survival advantage, which may or may not be there, it is definitely, or it seems to be related to the risk of myocardial infarctions. So finally, what happened with contractile function? Do we improve contractile function with revascularization? Stitch didn't show any difference in contractile function. Revived didn't show any difference in contractile function through our invasive treatment compared to medical therapy. So we come to the conclusion eventually about our paradigm on revascularization. Well, we treat ischemia and we treat ischemic symptoms. Yes, that's by coronary, increasing coronary flow capability. We do not improve contractile function. If we do it, there must be either it's a medical treatment effect or there is some acute ischemia ongoing at the same time, right? We prevent myocardial infarction, yes, and that's definitely so for CABG, and there may be a little potential for PCI. And we also improve CABG through that mechanism. We also improve survival through that mechanism. And again, because CABG is better in preventing myocardial infarctions, it has a greater potential for survival improvement. And PCI may be, and it may be so specifically in these left main lesions. And from that, I would like to suggest a paradigm shift maybe, or some new understanding of our coronary disease, because we have non-obstructive disease, and that progresses to obstructive disease, and the obstructive disease causes the symptoms, and that's when the patient presents. And if that progresses, then you get some infarctions, but that's only the minority of the fraction when we treat this. But the majority of patients actually get myocardial infarctions, a lot of them spontaneously without even knowing they had it, through this rupture mechanism. And that's the majority of actually all the things. And if you treat it all with the graft, but you need the great stenosis in order for the graft to stay patent, and you need to have a patent graft for the treatment effect. But if you treat it with the stent, you cannot deal with the distal disease. And that's why that's why the term revascularization is not really good. And I say that don't revascularize, but rethink and treat mechanism-based. And then we have these three treatment potentials: restoring coronary flow capability, reperfusion for the acute setting, and we have the second mechanism that applies in the chronic setting, and that's infarct prevention. And with that, I'd say thank you for your attention.
Thank you, Torsten. As usual, very insightful, very thoughtful. And I think it is a paradigm shift, because we need to understand that there's a field protection, a prophylactic effect for CABG that's not very well understood, that we need to make sure that we explain to our colleagues and our patients. I mean, yes, CABG is a bigger operation, but here is why CABG provides that extra advantage. And we also have got to be honest about the advantages of PCI, especially in the acute syndrome, especially in cases where the physiologic risk of the patient or when the patient is really frail, for example, the best way to go is a PCI. So now I'm gonna switch gear and hand it over to Elamir, who's an interventional cardiologist from Europe. Elamir, all the surgeons this last week from North America for the AATS and the STS, Europe, Latin America, and Asia have endorsed the European guidelines for chronic coronary syndromes. They have not done so for the ACC/AHA guidelines. So how would you talk to your audience today and to your colleagues across the Atlantic and convince them about ways to get together and come to a sensible consensus here?
Well, thank you for the introduction. I'm really honored to be here and to talk to you. And I would like to, let me just, do you see my slides?
No, yes, yes.
Okay, so I would like to present a couple of slides on the subject of, for example, left main disease that we did on our national registry in Sweetheart that has been published in European Heart Journal the other in 2023. And by that, I would like to make an push for observational data to be more rightfully cited and used when it creates the evidence. And then together with our, friendly dialogue between surgeon and interventionalist could perhaps level these differences that are perhaps not all in the right manner. So this is the paper from 2023 where we look at the patient with stable coronary artery disease and left main disease, and it has observations from 2005 to 2015, and it showed that bypass surgery was better in terms of mortality with an hazard ratio of 2. And then we did, these are my financial statements. I do not have any conflicts. And then at TCT in 2022, we did the other part of the cohort we have in Sweden from 2015 to 2022. So these are, all left main PCIs and bypass intervention that we did in Sweden since 2005. And what is interesting with Sweden, we have actually virtually 100% coverage of every PCI and every CABG in our registry. That's unique. And by using that, and by using some modern state-of-the-art causal inferential statistical models like instrumental variable analysis, which, by the way, I know that some might think this is unnecessary, details, but actually this way of addressing the causality by observation data have been awarded Nobel Prize in 2021. It's how we derive causality in econometrics and social sciences all the time. So in this particular study, 2015, 2022, building on what we have already published, was a PCI in CABG, 5,000 in a PCI group and 4,000, almost 5,000 in CABG group. And we look at mortality, and it also confirmed what we have shown between 2005 and 2015. CABG is better. Now, a nuance here. This is for me as an interventional cardiologist, what I would like our surgical colleagues to engage in a friendly and discussion about for individual patients. So fine, as an interventional cardiologist, I would admit and submit to you the totality of evidence coming from RCTs as well as from high quality observation data support the claim that bypass surgery is better in stable coronary artery disease in subgroups including left main disease. I would say I grant that. and we should stop, engaging in each other in some kind of pseudo discussions that are beyond the point of real data. So fine. Now, what is important to also take into consideration is how much is bypass surgery better than PCI? And then we can look at this graph where we calculated something that's called restricted mean survival time. It means if you are a patient with left main disease, and from the time of surgery or revascularization, you're expected to live 15 years, then you, on average, you will have a prolongation of lifetime with surgery compared to PCI of 6.8 months. But if you are expected to live less than 2 years, your lifetime prolongation expectancy will be 1.3 months. Now, if you ask myself, what would I, as an interventional cardiologist, knowing all this, would like to have if I have a left main disease or three vessel disease, knowing that bypass surgery is better, I would say, well, I would take bypass surgery if I was expected to live. I mean, at that period of my life, I will opt for surgery. But if I'm expected to live less than 2 years, I will probably opt for PCI. And that's my honest answer. And I think with the respect for principle of autonomy, we could include that in the individual decision making with heart team that has been mentioned. So, in summary, I would say number one, observational data should be part of the evidence, and in this particular field, observational data and RCT are actually confluent and support each other. And number two, I think it's important to take into consideration patients' autonomy, and actually we could quantify the contribution of one versus the other in terms of prolongation of life expectancy and quality of life. So that would be my take. Thank you.
Thank you, Elmir. That was fantastic. And I think you bring up a good point about personalizing your therapeutic approach based on a specific patient's age and condition. Because I think the guidelines provide the blanket recommendation for the average patient and the average doctor who treats that patient. And I think we're at a stage where we're beginning to realize that guidelines may not always give the best recommendation for that specific patient, and that the decision has to be individualized, especially in procedures like CABG and PCI, where surgeon skill or interventional skill set impact outcomes. But we're not going to focus too much about personalized care today. We're going to come back to the global issue of guidelines and come back to the panel here and also take some questions from the audience. And perhaps I could circle back to Don to lead the discussion here. Don, what do you think? Are we at a time where we realize we made the mistake in the 2021 ACC/AHA guidelines, honest mistake, and it's time to recalibrate given what the Europeans have come up with and given the fact that they received global support for their recommendations?
I certainly hope so. I mean, I think it's very clear from the opinions expressed by the surgical societies, and I mentioned just STS and AATS, but there were many others, LACES, I could name many that, expressed their strong opinion about what the 2021 guidelines did, and then also the 2023 guidelines. So I think from the surgeon's perspective, yes, we recognize the errors there, and what we need is for the cardiologists to engage in a dialogue and to understand and to come to a collaboration much as the Europeans did. You know, it's very striking to me. I had shown that slide showing the 2B, and it remains puzzling to me. I think it's, you know, very apparent if you're saying CABG has superior survival and PCI has non-inferior survival, how can they both be 2B when compared to GDMT? I don't know how to interpret the fact that in the 2023 guidelines, they basically stepped away from that controversy. They took that out of the document itself, but perhaps that is an indication that they recognize this was not the correct thing to put out there. I just want to step back really quickly to what Elmir just said about the survival. I think, you know, there's a lot of nuance we've talked about with mechanism, with individual patients. But I think there's also nuance as to if there is not a clear, long, or great magnitude of survival benefit, there's also emphasis in the guidelines about quality of life and symptoms. So I think that is something we also should account for.
Thanks, Don. You know, I'm going to go steps backwards in the workup of the patient. And one of our audience members, Asme Gassa, hopefully I'm saying the name right, she wondered whether the cardio CT scan would be a useful first line to evaluate coronary artery disease and determine management options. Mike, what do you think about CT coronary angiograms?
Yeah, I mean, it's become into favor, particularly in the American practice. And I think it's bode well. I think that we've used it, and I think that we will use it better as we can assess the level of ischemia as well, non-invasively through CT scan technology. So I do think that's the way we're moving. If you think about how we evaluate patients, it's been putting them on a treadmill, and to Torsten's point, even if they have non-inducible ischemia, they can still die the next day from a non-obstructive lesion. And so the idea that we're fooling ourselves into a billion-dollar, multi-billion-dollar industry of stress testing, I think this will be abandoned in the years to come. It's been surprising to me as a clinical cardiologist that anatomy trumps ischemia when it comes to the way we intervene on patients and the outcomes from clinical trials. And no greater example than Stitch, which is the sickest patients, and where ischemia was not relevant in terms of predicting who would benefit.
Mike, how far are we from a pill or a set of pills that would actually halt and reverse atherosclerotic lesions in humans reliably and consistently so?
I think we're near there. We've done some work on the polypill strategy. My mentor, Valentin Fuster, published his paper just a few years back, showing that if we treat optimally on multiple fronts with a single pill, which is adherence, deals with the issue of adherence, that we can achieve optimal medical therapy to stabilize the patient. What you're talking about are technologies that can reverse the pathophysiology, and I think we're getting there too with some new strategies where we can actually regress plaque and treat at the molecular level to reduce macrophage and lipid accumulation.
So Torsten, until then, until those magic pills become available, CABG and PCI are going to be useful. So my question to you is this: there are lots of studies that show that if you bypass a moderately diseased vessel or stent a moderately diseased vessel, that actually you may increase the rate of atherosclerosis in that vessel. And the data is probably stronger when you use a vein graft than when you use an internal thoracic artery. So how would you factor that in when you do a multi-vessel bypass?
That's a fantastic question because it all addresses pathophysiology. And I think that, you know, from maybe if I can say, take a little detour and comment on some of the things that Dawn said and Michael as well. I don't even have a problem in understanding why the recommendations in the guidelines are so different, because it depends on what you aim for. And if you look at sort of survival advantage differences of a few months, then of course you may say, well, that's not worth it, and that's why we don't bother. And then you end up looking for, if you have a mortality difference, then you have to have a big treatment effect, and then this is not worth going for, you know. But the other thing is that if you if you follow that thought, then you can understand also European guidelines, because if mortality is not considered the only important endpoint, because we had this discussion in this committee, is a myocardial infarction a relevant endpoint? Is cardiac death, with all the difficulties in assessing it, a relevant endpoint? And if the answer is yes, then you come up with the recommendations, and then you, of course, you have only a limited number in your trials and in your evidence as a representative samples for all patients in the world. And that's why, you know, these guideline recommendations are sometimes saying it's for survival, sometimes it's for cardiovascular death, and sometimes it's for myocardial infarction prevention or so. And then if you look at from, and then all of a sudden, if you think along those lines, then these mechanisms always come back into play because they unify the whole concept. And that's why I think that the current European version have had so much appeal, because it addresses these things, and it provides somehow a unifying concept, even though only addressing evidence, you know, and not trying to explain it by mechanisms. So then if you go with these mechanisms, and now I'm back at your question, Faisal, yes, if you create a road, you know, that circumvents, let's say you have a road from one village to another, and that road is all messed up and you have a lot of holes in there, and then you have to fix it. And the one way is to put a stent to fix a hole in the road, and the other one is to put another road leading it around it. So the more cars will drive over the road, the collateral, so to speak, the less activity will be on the other road, and that will probably grow, you know, stuff. And that's why I believe that the placing a graft increases the chance for the original vessel to because there's less flow, and then there's less repair mechanism, and to increase the disease there. And with PCI, it's known that a metal stent that you place, whether it's drug-eluting or not, causes a chronic inflammatory response. You can measure increased CRP levels in stented patients for months. So there's a chronic inflammatory reaction that will also affect the rest of the disease. So that's why I believe it is so important to have a conservative cardiologist in the heart team, because there are many situations where it may be best not to do anything at all. You know, because we're always saying we need to decide between CABG and PCI, but oftentimes we may decide not to do anything, because if we have PCI as an option that does not prolong life, and we do not want to exploit a prognostic potential with CABG, why do anything? I mean, this is a road also not very popular in the industry setting, but maybe from a patient perspective, it's something that we should, as physicians, actually pursue.
Well, you know, it's interesting because my father had CABG over 30 years ago, and I show his slide in most of my talks, and his left main is down and his right coronary artery is down completely. The only reason he's alive is not because of stents or optimal medical management. He's alive because of a lead tattoo LAD that supplies the entire heart through collaterals. Now, every now and then I get a patient with an LAD metal jacket. And I say, well, what's the way forward here? A stentectomy? Why wasn't that patient referred to me earlier? So I'm going to turn the spotlight on Elmir and say, hey, is there a role for a metal jacket in a patient that otherwise is physiologically fit for CABG?
That's a tough question. We would like to have a stent technology that disappears, and it is, you know, making some progress, perhaps not as fast as we hoped, but I think if we have a stent technology that could, in a reliable way, you know, make the way for blood to pass by and then disappear as resorbable, some of them are, you know, showing the progress, but it's not mature stent platform yet. Hopefully, we'll be able to coexist if we can have something that is anti-inflammatory, as Torsten pointed out, make, you know, the initial, you know, thing that it has to be, you know, make the place for normal perfusion, and then disappear later on that we can re-intervene with CABG when all, the totality of the coronary artery disease becomes much more pronounced. So I think that's one way of tackling that. Full metal jacket, well, I don't know. It's for every, I can add to Torsten's, for every millimeter increase in metal in the vessel, you increase the risk of restenosis and stent thrombosis and myocardial infarction and so on. So it's not, maybe for some patients, yes, but as a long-term solution, I don't think that it will hold.
So I have a quick question from the audience, from Mohammed Al-Aboud. He goes directing that question to you, Elmir, and he says, when you do a PCI and you compare it to CABG, yes, there may be a small incremental difference in survival, but what about quality of life and angina control that might be more effective with CABG? You're not adjusting for
that should be taken into account. When I took you took your father as a personal example. That's a great way of testing your ethics. What would you do if it were your father? What would you do if it was yourself, your sister and brother and so on. Yeah. So I was honest when I said at the age 55, as I am now, I would choose PCI if I have complex coronary artery disease. Mm-hmm. If I'm at 70 and something, then I will now I will take CABG, and I would like Torsten to operate on me. And if I were 70 or something, I would probably opt for PCI. That's my honest answer, including my knowledge that bypass surgery is not once or twice better when it comes to the risk of angina. It's time 5 times 6. I mean, I take into the consideration. So, but that's me. The principle of autonomy actually says, for me, that's my caliber. But for someone else, you, Torsten, and everyone else, it may mean something else. This 6 months or 2 months may mean something completely different. So what we, I think, are not doing properly in terms of patients' inclusion and decision, both surgeons and operators, PCI operators. So we are not, that's my honest, admittance, at least from my practice, we are not taking as much as we should patient preferences into decision.
Maybe what we need to do is, as the aortic valve guidelines, they use age as a proxy for life expectancy, but that's maybe what the coronary guidelines need, the stratification accounting for life expectancy, in addition to patient preferences.
Great point, Don. And Hiro Tsukui sent a message through Q&A saying that how can we create a heart team atmosphere for management of coronary disease that's similar to that for transcatheter valve therapies, where we get together with the cardiologist and make the best possible recommendation for treating our patients. We have 5 minutes left, so maybe I would ask each panel member, starting with you, Don, to give us about a minute of wrap up, and then we'll move along the panel members for closing remarks. Don.
Thank you. Well, my wrap up, I'm really going to just, I think, echo what my very wise colleagues have said. There is, I think, needs to be an inclusion of mechanism into making recommendations, and we need more understanding of that, as Torsten has shown. Just echoing that we need harmonization of the guidelines in order to move, because we all see these patients in different scenarios, and it really comes down to the luck of the patient as to who saw them first and what kind of provider saw them.
Mike?
Well, first of all, it's been a pleasure to participate with everyone. Yeah. I think there are nuances here, and I want to take us to the next stage, to be more sophisticated. If we think about bypass and PCI, if they had equal morbidity to the procedure, if the procedures were equal in their morbidity, there's no question in my mind that people would default to bypass. And I think that that is one of the issues that comes into play when we present these options to patients. And that is in the patient that requires revascularization. Underpinning it all is optimal medical therapy. And I'm going to say it again, if we don't have optimal medical therapy, if we don't espouse to that, then we fall down. The whole argument falls down. So let's treat this as a systemic disease, treat all lesions, and treat the patient optimally. We'll get the patient at least 70 to 80% of the way there. And then how we revascularize really comes down to the nuances from the clinical trials and the severity of the disease, as we've highlighted. The second is operator competency, where you're getting, how competent is the operator to treat some complicated and more advanced disease. That's got to be in the picture as well. Adherence to the medical therapy has to be assessed as well. And of course, we have to understand our practice. If the interventionalist sees the patient first and decides what to do without going to the heart team, then the whole guideline falls apart. So the idea is we need to have the heart team approach so that every patient has the opportunity to see a clinical cardiologist, a surgeon, and a PCI and an interventionalist to make the decision. We have to be more sophisticated in how we approach this. If it's a one-shot deal, patient with multivessel disease, they're going to get X, Y, or Z. We're not being sophisticated. We're not in the 2025. We're back in 1970. Thanks very much.
Thanks, Mike. Thank you. Torsten.
Well, couldn't agree more. I would say think mechanistically and then use the data that are out there to inform patients. And I'll give you one example for what I mean by that. Who knows the 30-day mortality of PCI? We all know PCI 30. We all know 30-day mortality of surgery. That's the SDS score, right? But we don't know it for PCI. And if you look at the randomized data, I'll give you a little teaser. There's no difference. So if there's no difference in short-term risk, maybe we need to look at a little bit longer, a little bit more at the long-term outcomes and then decide, and then maybe go for conservative treatment in the one or the other way. So, but that's it. But so think mechanistically and then treat, inform the patient correctly. The patients often know exactly what they want.
Wise words. Elmir?
Yeah, thank you. I agree with everything that has been said so far. Maybe I could add, there's no secret in how the things are in the world. Who is the gatekeeper? Well, that's PCI operates. We do angio and we are first to diagnose, and then we kind of control of the patient flow. And perhaps it's not right. That's one thing. The other thing is that we really, on behalf of PCI operators, I think we should really admit the totality of evidence from RCTs as well as from observational trials supports the claim that bypass surgery is better in terms of, major adverse cardiovascular events, including quality of life and survivor benefits. So that's fine. And we should avoid this pseudo-scientific engagement and unproductive discussions. And the third point I would say, having said all that, and I admit that bypass surgery is better as an interventionalist, I would say principle of autonomy needs to be respected when it comes to the individual patients. And they should be included through mechanisms of heart team by their own representative, or if they perhaps may represent themselves. So that would be my take on the subject.
Thank you so much, Elmir. And I'd like to thank every single member of this fantastic panel. I enjoyed it a lot. I'd like to thank CTSNet for the privilege of getting us together. And I'd like to thank our audience for joining us and being interactive today. And I'd like to close by saying that we care about our patients and we want to do what's best for our patients. And when it comes to guidelines, we have to be on the same page together as a multidisciplinary team, surgeons, cardiologists, interventionalists. And perhaps I'm going to conclude by one of the comments made by our audience, Gabriele Iacona, who said, it's time to get together and have a transatlantic guidelines for coronary revascularization.
I salute to that.
Thank you. John, I'll turn it over to you.
Thank you for attending the CTSNet original webinar. As a reminder, a recording of today's webinar will be available next week on ctsnet.org and CTSNet's YouTube channel. Please look forward to more CTSNet original video series, video competitions, and webinars to be announced early this year. Have a wonderful rest of your day.
Thank you, guys.
Thank you.
Bye-bye. Take care.
Take care.
Everyone.